In this webinar, we will learn the monitoring, maintenance and weaning of CPAP. After initiation of CPAP, subsequent titration of pressure, flow and FiO2 involves mostly clinical assessment. Flow is immediately adjusted to obtain continuous bubbling in the bubble chamber. A flow requirement of greater than 7 liters per minute is an indication that there could be air leaks in the CPAP circuit. FiO2 is adjusted from a range of 21 to 60% for a target newborn saturations between 90 to 95%. CPAP pressure is adjusted based on the recessions, chest expansion on the X-ray and the saturations. Increasing recessions mandate increasing CPAP pressure provided there are no leaks in the circuit and there is no airway or nasal block. For most clinical situations, when a newborn with respiratory distress is supported with CPAP, one expects a proportionality of CPAP pressures with FiO2 needed to maintain the target saturations. For a FiO2 requirement of 50%, the maximum CPAP pressure expected is about 5 centimeters. Likewise, for 60%, CPAP pressure is expected to be 6 centimeter. For 70 to 100% FiO2, a pressure requirement greater than 7 centimeters or more is expected. When the newborn maintains target saturations with FiO2 less than 30%, the CPAP pressure may be dropped to 4 centimeters of water. Whenever a newborn is supported on CPAP, the ideal CPAP pressures are from 4 to 7 centimeters of water. CPAP pressure of less than 4 centimeters is not indicated and that greater than 7 centimeters is associated with complications such as air leaks, CPAP belly and airway discomfort. The crux of CPAP application, apart from providing air oxygen mixture at a constant pressure to the airway, also includes appropriate warming and humidification of the gases. All gases delivered to the nares in CPAP should be delivered at 37 degrees Celsius and at a relative humidity of 100%. No condensation, but for a mist is acceptable in the inspirator limb and some condensation in the expirator limb is acceptable. The temperature display on the humidifier should be 37 degrees Celsius to ensure appropriate warmidification of the respiratory gases. In this figure, one can see the display of 37 degrees Celsius on the humidifier. It also shows the temperature changes that occur in the inspirator limb as gas passes through it before reaching the patient nares. A newborn supported on CPAP needs 3-phase monitoring: monitoring of the patient for adequacy of CPAP settings and for assessing the complications, monitoring of CPAP machines for air leaks, water condensation, water level in the bubble chamber and the humidifier, and the interface for nasal injury, nasal block and appropriateness of CPAP and interface size and fixation. A chest X-ray is indicated for all newborns on CPAP. Chest X-ray is indicated immediately after starting the newborn on CPAP to assess for lung inflation and also for evaluating the etiology of respiratory distress. A lung expansion of 6 to 8 intercostal spaces is considered appropriate. Low volume lung require increase in CPAP pressure and increased lung volume would require decrease in CPAP pressure. For the X-rays shown here, the first X-ray mandates increase in CPAP pressure and the second a decrease in CPAP pressure. Chest X-ray is also indicated when a newborn on CPAP has a sudden unexplained deterioration or when there is a discrepancy between the requirement of CPAP pressure and FiO2. A newborn on bubble CPAP is considered to have adequacy of settings and does not require any change in flow, FiO2 of or CPAP pressure if he or she is hemodynamically stable, is comfortable and not fighting, there is no or minimal recessions and no grunt, capillary refill time is less than 3 seconds, heart rate, blood pressure are normal and urine output is adequate. Saturations are between 90 and 95%. If a blood gas is done, it has a pH between 7.35 to 7.45, PaO2s are between 60 to 80 mm of mercury and PCO2 is between 40 to 60 mm of mercury. Also, there should be bubbling in the bubble chamber and bubble sounds should be heard in the axilla. If a newborn on CPAP is well settled and the disease process for which the CPAP is started is improving, there is a need to wean FiO2 and CPAP pressures. When the CPAP pressure is more than 5 centimeters and FiO2 is more than 50%, always first reduce the FiO2 in steps of 5% and then decrease the CPAP pressure in steps of 1 centimeter. For every 10% reduction in FiO2, aim for a reduction in CPAP pressure by 1 centimeter. After reducing the CPAP pressure to 5 centimeter, subsequent reduction in CPAP pressure to 4 centimeter is done only when the FiO2 could be dropped to less than 30%. When the CPAP pressure is 4 centimeters and FiO2 is less than 30% and the disease process has improved, remove the newborn from CPAP. After removing the newborn from CPAP, the nose should be cleared of any secretions and a frequent change in baby position is recommended. Watch for increasing FiO2 need, increasing recessions and heart rate fluctuations. There is no need for routine chest X-ray after removing a baby from CPAP. Any baby who continues to have moderate to severe recessions, grunt, saturation less than 90%, has recurrent apneas even on a maximum CPAP settings of pressures of 7 centimeters and FiO2 of 60% or more is a candidate for mechanical ventilation. This is considered as CPAP failure. Always assess for appropriate delivery of all the components of CPAP before labeling CPAP failure. Those newborns who do not have good respiratory efforts and those not tolerating CPAP machine may also need mechanical ventilation. The commonest reason for CPAP failure or need for mechanical ventilation are the failure of CPAP delivery system or baby related events such as worsening respiratory distress, cardiovascular instability or recurrent apneas. To summarize, titration of flow is based on the presence of bubbling in the bubble chamber. FiO2 is titrated to maintain saturations between 90 and 95%. CPAP pressure alteration, that is increasing or decreasing CPAP pressure, is based on the presence of recessions, lung expansion on the chest X-ray and on the target saturations of 90 to 95%. When giving pressure and oxygen, always remember the concept of proportionality. A systematic evaluation is always required before confirming CPAP failure in any newborn. Thank you.